has started.
I can confirm, Chair, that we are now live streaming.
Thank you. Welcome to this meeting of the Health and Wellbeing Board being held on Monday the 10th of June 2024. For those present in the meeting room, if the fire alarm sounds, please leave the building by the nearest exit and proceed to the assembly area in the car park. The agenda papers and other relevant information for this meeting are available for public viewing on the Herefordshire Council website. The Council is streaming this meeting live on the Herefordshire Council YouTube channel and is making a recording. To ensure that recording quality is maintained, please speak as clearly as possible and keep background noise to a minimum. Please ensure that mobile phones and other devices are turned to silent. Others are permitted to film, photograph and record our public meetings, providing that it does not disrupt the business of the meeting. If there are any members of the public present who do not wish to be filmed or photographed, please raise your hand now so that any such person filming or photographing may be made aware. Fine, and we take that on board. So we recognise the two lads. I'd like to introduce them. These two lads are work experience, and they are with the council, I think, for a week, and they have joined us today for our Health and Wellbeing Board meeting, which I think is your first meeting that you've attended. So I hope you enjoy it. Voting will be undertaken by a show of hands in the room, and only committee members present may vote. For participants in the room, please use the microphones to speak, pressing the button on the right-hand side of the unit, and speak directly into the microphone. We have a number of people in attendance as virtual participants, and can I request that they use the raise hand function within the system if they wish to contribute. If your hand system doesn't work, well then you will have to raise your actual hand. Thank you. We now move on to item 1 of the agenda, which is apologies for absence. Do we have any apologies, Henry?
Apologies have been received from Ross Cook, Sue Harris, Hilary Hall and Simon Trickett.
And I understand, Helen, that you need to leave at 3:30. Is that right? Thank you. Do we have any name substitutes, Henry?
No name substitutes.
Thank you. Do any members wish to declare any table A and or table B or other interests in any of the agenda items? No declarations of interest? No? Okay, we move on. We now move to item 4, which is the minutes of the previous meeting held on the 11th of March 2024, which are included in the agenda pack at pages 7 to 16 for approval. I have received no notification of any amendments to the minutes. I move the minutes subject to be signed as a correct record. Do I have a seconder?
Yep.
All those in favour? Any against? No? Okay. Item 5 is questions from members of the public.
No questions received.
Item 6 is questions from councillors.
No questions received.
Thank you. I'm now going to change the order of the agenda and bring forward the item on the autism strategy, as Valerie Fitch has come today as a member of the public, and I think it's only fair that item should be brought forward to enable her not to have to stay to the end of the meeting, although I'm sure she would have enjoyed it thoroughly. So can I ask Hayley Doyle to present the report? Thank you.
Thank you. So thank you for the invite today. We've come along today to introduce to the Health and Wellbeing Board the Herefordshire and Worcestershire All-Age Autism Strategy. The strategy was approved by Cabinet on the 28th of March this year, and most of you will be aware that we saw the introduction of the Autism Act in 2009, which is the only disability-specific legislation in England. We saw statutory guidance published for the NHS and local authorities to implement a local strategy to improve staff training, identification and diagnosis, and improve transitions for children to adult services with a focus on employment and criminal justice. So in September 2022, work began on an all-age autism strategy in line with the national published autism strategy, and the work was across the integrated care system, ICS, and that's across Herefordshire and Worcestershire. Across the two counties, there was a significant co-production approach involving lots of autistic people, carers and professionals, and there was a combination of activity in relation to workshops, online surveys and focus groups with people to shape the strategy. There was over 400 responses to the online survey, and those have been used to shape the development of the strategy. The work across the two authorities has been overseen by the Autism Partnership Boards in both Herefordshire and Worcestershire, and the strategy identifies 7 key themes, and they are understanding and acceptance within society, children and young people having access to education and transition into adulthood, support into employment, tackling health and care inequalities, building the right support in the community, support in the criminal justice system and keeping safe. It is aimed that the next step of the strategy will to be develop detailed action plans for each of the 7 key themes, and the progress against these action plans will be monitored at the ICS Developing Services for Autistic People Board, with oversight from the ICS Learning Disability and Autism Programme Assurance Board. It is also envisaged that annual reports will be presented to the Health and Wellbeing Board in both counties. The autism strategy aims to deliver really positive outcomes and improve the lives of a number of individuals from different areas across the local communities. The strategy provides us with the platform to elevate the profile of autism and aims to facilitate significant and meaningful change. It should enable more support for autistic people, removing barriers, removing discrimination and ensuring that professionals work with empathy and increased knowledge. The strategy aligns to Herefordshire's joint health and wellbeing strategy and sets out how the council and local partners plan to address health and wellbeing needs of its population. In the strategy, the health and wellbeing strategy is a key document that's jointly owned, and this promotes collective action. And that's one of the reasons that we wanted to bring the autism strategy today. The key themes within the autism strategy align to the themes within the health and wellbeing strategy, and the priorities set out within. This includes enabling the best start in life for children and good mental wellbeing throughout life, and additional priorities addressed in both strategies will include improved access to local services, good work opportunities for everyone and support for people with complex vulnerabilities. The autism strategy has also been developed to support our compliance with the legislative framework, and I'm now going to hand over to Valerie, who's kindly joined us today, to take us through the strategy from a lived experience perspective.
Thank you, ladies and gentlemen, and as Groucho Marx says, I think that covers most of you. So I'm going to give you a very personal explanation of autism and how it affects people through their lives. And fortunately enough, you've got that up there on the screen so you can see. So if we turn to the next page, I've only been given 15 minutes, so I'm going to be quick. You can see all of the different things that I'm involved in, simply because I want to make Herefordshire a better place for autistic people, not just myself or my son or my husband. It's for all autistic people. So the first line there is what's important, but the bottom line is the most important. I am a human being, and I hope all of you are. So consequently, we are the same, and we should be treated the same. Next slide, please. This is the first one, improving understanding and acceptance of autism within society. And it works both ways, okay? So I'm just going to give you the first personal example, which is me. Over 50 years ago, yes, I am that old, over 50 years ago in my first job, I worked for Hewlett-Packard as an input operator. Some of you are old enough to understand what that means, what life was before computers. And Hewlett-Packard had a teleprinter. And a teleprinter is something that you tap, 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 tap. And if you see black and white films, you will see ticker tape coming out. And that's what I used to do. I used to change handwritten orders from the order department into this strange system, which then enabled the orders to be done. After 3 months, I was given my first appraisal. They loved me. Thank goodness for that. I was given a 33% salary increase. Just imagine that, if you all got that today, what that would mean. Right, wow. But the human resources lady said, we have had one complaint about you. What's that? I wanted to know. And she said, you don't talk much. And I really gave her a funny look. And I said, excuse me, I thought you paid me to work. I didn't realise you paid me to talk. So she gave me a funny look back, most probably realising I wasn't normal, and said, well, you can only talk a little bit. So I said, okay, went back to my teleprinter. And when the first person came in with the order, instead of just saying thank you and putting it to the bottom of the pile, I said, thank you, look, the sun is shining today. Thank you, it's raining outside. And you know, 50 years on, I still don't get it. I still think I'm paid to work. So, next slide, please. This is most probably the saddest one, really. Now, remember, I'm talking a long time ago when things were different. So this highlights the fact it's not just autistic people who need help. It's actually the support staff and professionals that need help so that you can understand us and help us properly. And this is this example. My son, at the age of 2.5, could not talk. I can't stop him now, but at the age of 2.5, he couldn't talk. And of course, it's quite important. He's going to be going to school soon. So they wanted to find out what his level of intelligence was. So he sat on my lap as we went through the questions. And of course, he had to point at different pictures. And then it came to a lovely question where the lady said, who does the washing up in your household? And she held up 2 dolls, one with a skirt on and one in trousers. My son picked the one in trousers and she marked him as being wrong. Now, 40 years ago, it might have been slightly different, okay, but she marked him as wrong. And I could no longer keep quiet because this was wrong. He'd picked the right one. She refused to change it and kept him marked as being wrong. But as I explained to her, when my husband does the washing up, he doesn't wear a skirt. And when I come home from work, I take off my skirt and put on trousers. So he's picked the right doll. No way would she change it. And I feel that's, quite sad because he was actually put down as having an IQ of only 65. And they classified him as being severely mentally retarded. Just imagine how that will start your life off and the disadvantages it will give you. And it certainly did. On to the next one, please. This is a lovely one. How many of you remember Sara Lee cakes? Yeah, they're still made, aren't they? I can never, ever bring myself to buy one or eat one. I still choke on them. And this is the special employment advisor who was trying to help my son get a job. She was brilliant. She could see that there was potential here. And so when Sarah Lee had a job that she thought would suit my son beautifully, she phoned them up. And this is what she said to them. If you take Eric on, we will pay his salary for the first 6 months in full. Furthermore, for the following 6 months, we will pay 50% of his salary. We will also provide a taxi to get him from home to work and back again, to ensure he always turns up on time and does a full day. And because there's training involved, we will also train the trainer person who will be trained at the same time as Eric. And if Eric doesn't get it after the set training period that you would normally do, that the trainer will then sit and train Eric until he becomes proficient. And finally, we will sing your praises to the world. We will tell them what a nice employer you are, caring for disabled people and giving them a chance to live. You know what the answer is already, don't you? They didn't, even with all of those incentives, they didn't offer him the job. Imagine how you personally would have felt if that was you. So yes, I still choke on Sarah Lee cakes. Next slide, please. I'm pleased. I didn't know we were going to have so many people here from, different organisations. So I'm quite pleased we've got you lot here, sitting next to me, because here we have, under this one, that diagnosis is so important. And we know there's a big shortfall at the moment. Children are not being diagnosed. CAMS can't cope. And so, of course, you get a lot of children who are ending up coming into adulthood who still haven't received a diagnosis. My son was like that, but in his day, there was an excuse. Because, of course, we didn't know about autism in those days. It was something unusual. He was just odd. There was something about him that wasn't quite right in other people's eyes, but they couldn't find out what that was. Now we don't have that excuse. Now we have a proper system, but we must bring that down, because for my son, he was affected again because he was in his late teens by the time he was diagnosed. And most of his educational life had passed by then. And you may remember that he was only had a 65 score on the IQ test. Of course, he didn't have a 65 score. He's bog standard. When he was retested, of course, he's just 98, which is, you can't get more average than that. And he did pass all of his exams. And he also studied 2 A-level subjects. But because of his autism, he was unable to do the coursework. He needed people to be on top of him all the time, having set structures. And of those of you who've done A-levels, you know it doesn't work that way. And so, of course, he was constantly, again, held back in his life. Priority 5, please. Next slide. This is the good news one. I really want to take this opportunity of saying thank you very much to the council, because building the right support in the community works. And for those of you who were paying attention earlier, you will see that Eric is washing up and he's not wearing a skirt. Okay? And he's also doing the vacuum cleaning. He does it better, both of those jobs, than my husband, who is now 74, still has difficulty in doing those 2 jobs. Our son has beaten him. It's brilliant. And he's now in a supported accommodation place in Hereford. and what a difference it is making to him and his self-esteem. We can do it in Herefordshire, but we need more places for people like my son to be able to be moved into with that type of support. He may never be fully independent, but this is brilliant. And people have noticed the difference in him even after 3 years. So it's good. So well done, Herefordshire. On to the next slide, please. Yes, the criminal and youth justice system. As you saw, I help the police as an independent person. And if we have any autism cases and an autistic people would like to speak to somebody who understands them, they get passed on to me, but only if they want to. But let me just show you how easy it is to get into trouble without even realising it. And more importantly, how you can put yourself in danger from mob rule. I don't know how many of you have heard about poor autistic people who've actually been murdered by their local people because they've been misunderstood. So let me give you this lovely example, which still makes me smile. Actually, it shouldn't do, but it still makes me smile. We gave our son a camera for his birthday, and it was a video camera. Every night, because we're autistic, so we have our set routines, Dad and he would go out for a walk in our local area. Obviously, it's in the dark. And he's got his camera and video with him. He's dying to use it. So on my particular estate, there's a nice little place with a bench. As soon as my husband sees a bench, there's some magnetic thing in his bottom which makes him go and sit down. And he can stay sitting down forever. My son is like me. He can only sit down for a second or two. So he got up to start taking videos of the local thing. Unfortunately, a gentleman was driving past and saw what he perceived as most probably 2 paedophiles, because my husband and son didn't know that they were actually sitting outside a house with a lot of young children. And so, of course, what they saw my son doing looked rather suspicious. So they followed my husband and son home, and then they called the police. On Sunday morning, I woke up, much to my amazement, to the doorbell and seeing a police officer outside. He was just as amazed to see a female, because, of course, he thought there were 2 gentlemen who lived there. I said, "Can I help you?" He said, "Do 2 men live here?" And I went, "Yes." I said, "My husband and son. Do you think you better come in and tell me what this is about?" So to cut a very long story short, my son was really happy. He was in bed. It's Sunday morning. And the police officer was pleased to see what he'd been videoing. Nobody likes seeing my son's stuff, and you will understand why very shortly. So I shout upstairs, "Eric, there's a policeman down here, and he wants to see the videos and pictures you took last night." So, of course, he jumps out of bed, he grabs his camera, and he comes rushing downstairs, pleased that someone wants to see. Remember, this is in the dark. So he shows the officer the first one, which is of a black cat that jumps up onto a wall and walks along it. The second one is of a snail, my son's favourite animal, that was crawling up the wall. And the third one was of a spider. When he got to the spider, the police officer said, "Oh, that's enough, thank you, thank you." And my son was quite disgusted that the police officer should be scared of spiders. But I'm pleased to be able to tell you that the gentleman who reported them and the family that were there were happy with the explanations, and we're okay. We didn't end up having mob rule. But see how easy it is to be misunderstood? So, next one, please. Keeping safe. And again, I've already told you, my son has moved into a flat. He doesn't like the telephone. Most autistic people actually don't. We can't see you. We find it difficult understanding what you're saying to us half the time anyway. So we need to see you to help us understand you. So we don't like telephones. But we had to get our son a telephone so that we could contact him should we need to. And we'd got him trained in the fact that he could answer the phone. That was the difficulty. I never thought, stupid me, that I needed to educate him on when not to answer the phone. And sure enough, we had a scammer very soon after he'd moved in. He asked him for his name, date of birth, address, and then he started to ask him for his bank details. Fortunately enough, as I have lasting power of attorney for the finance of my son, he wasn't aware how easy it was for him to know his details. So he said to the gentleman, "I'm really sorry, you'll have to wait until tomorrow at 5 o'clock when my mum comes, and she'll be able to give you those details." And then obviously the person, the scammer, hung up, and we never heard from him again. But can you see how easy it is? And this is why the autistic fraternity in Herefordshire wanted this priority added. It was only going to be 6, and we persuaded the police and Worcester to have this added in. And this is because of those types of things which actually are not included under any of the other items. So, the final slide. I'm obviously the chair of the Autism Partnership Board. We worked hard, as Hayley has already told you, in making this come true. And so we want to say to all of the 7 leads, you've got to come and see us. You've got to come and show us what your targets are going to be for each of the 5 years. But also, we want you to come back and tell us what you've actually achieved. And if there was a problem, why was there a problem? Because actually, you know, we're not there to moan, we're there to help you. Because by helping you, we are helping us. So thank you very much for listening.
Thank you so much, Valerie. That was a really, really interesting and personal discussion around your family's experiences. And before I open it up to the rest of the meeting, I'd just like to say that on Friday morning, I went with one of our social care assessors to a supported living accommodation in Hereford, where I met some autistic young people between the ages of 18 and 25, which was a really interesting and enlightening experience. And they too were doing lots of things that previously they had been unable to do, and they had they were very, very keen to be able to use those skills within employment, but were finding it very difficult to achieve that. So I understand exactly where you're coming from. So I meet if anyone would like to ask any questions on the strategy or anything that Valerie has said.
Thank you. That was really, really well said. Having worked with Eric recently on a video that we did, it's all twigged now where we've met before. So, yeah, I just wanted to add, really, I mean, obviously very supportive of the strategies, that's quite clear. But one of the big areas which I think you highlighted was around the kind of delay in getting diagnosed. I just think we need to be more explicit around, as a board, what we expect from that and what we'd like to see in terms of something, because I think it is a significant delay, and I would love to kind of understand what the weight is currently, because I think it is quite a challenge for, particularly for parents, I think, really, in terms of trying to, because it is often, you have to know the system, and I don't think that is supportive of the individuals involved in some of that, and I think that exposes inequalities in itself. So there is something for me around us being clearer around some of those timelines and what the expectations we'd like to work towards, recognising, of course, there are challenges with regards to that, but I'm sure there's more support that can be put in earlier for these folk when they're on that pathway at schools and communities, and how we join that up. And the second point, of course, is, like with any strategy, is making sure that we keep on top of actually of delivery. because one thing having it, and then the second thing, of course, is going to be making sure it's delivered across all partners. And I think I'd just like to be clear about some of that aspect of that, and perhaps, given recent conversations have been explicit around whether that function will sit, where that will sit, and to what degree, for instance, the One Herefordshire Partnership may play a part or not in that, would be good to at least understand that from the get-go. Thank you.
Thanks, Mike, and thank you, Val. That was really, really interesting. So I'm Managing Director of Wye Valley, and we run the Community Paediatric Service, which is the first service in terms of diagnosis. It's absolutely the case that the wait is too long. And there is a workforce difficulty, a recruitment difficulty into this specialty. So there's a range of things that we've been doing. There isn't a quick fix that's going to be next week things are going to be better. But one of the things we've commissioned is a regional review to see if there's a different shape of our workforce, some different practitioners that we could use from the way that we've traditionally done this. So we're on it in terms of recognising it's a problem and recognising that we need to get these weights down to a much better position. And I guess our particular concern is around the preschool children, because that's where it can make the most difference. So we're putting more resources into that area, and we are regularly reviewing it and looking at any other things that we can do, from learning from elsewhere, best practice from elsewhere, to get the diagnosis delay resolved so that we can do this in a quick time.
Anybody else? Mike, sorry.
Mike. Thanks, Valerie. Really insightful lived experience. I thought it was really powerful. It's just a note around the links around mental health needs, which is highlighted in the strategy. And obviously, we've got an item today on mental well-being. So I think there's already established links around the suicide prevention group. And we've got a new suicide prevention officer in post now in Herefordshire. So I think that will provide a lot of kind of support and resource around how we can target this cohort. And then we probably just need to link it into the Better Mental Health Action Plan. So my colleagues on the left, we're talking about that later. We just need to make that link if we haven't already done so. And then the Children's Emotional Wellbeing Partnership too. So it's just connecting all the dots really to make sure we're supporting this strategy and delivering those specific ambitions. But other than that, I think it's a really good strategy. It's good to have that collaboration with Worcestershire as well. And it makes sense to kind of work at scale where it makes sense to do so. So thank you.
Just one of the key actions is about learning and training. I was wondering, it mentions within health settings whether it could be extended out to the voluntary sector to join and raise their awareness across there, rather than just statutory services, so everyone's getting the similar training at a similar time. Because whilst there's some voluntary sector, charitable sector working specifically in this space, a lot of them don't, but may come across individuals who would benefit from that knowledge. So it's just an ask, so whether that training could be extended across.
Yeah, so I think you're probably talking about the Oliver McGowan mandatory training in that context. I believe, I'd have to confirm, but I believe we're already having conversations with a team who are rolling out the training about looking at wider groups that can access the NHS training package on it and the wider training package on it. I mean, from the NHS perspective, we're aiming to have 40% of all staff trained by March next year in this programme, and then we'll be looking to roll it out as much as we can beyond that. I know we've talked to the police about potential joint training packages and the like, so yes, on that, but I can't give you a definitive answer at the moment.
Thank you, Valerie. Jonathan Lester, leader of Herefordshire Council. I welcome the strategy. It's a very good strategy, I think, and appreciate all the work that's gone into it. But there's nothing more powerful than personal experience and relating a personal story. And it sounds disrespectful to call it a case study, but if we just talk about it as case studies, that tells you more than any strategy will ever tell you, and I think it's really powerful. So first of all, thank you for coming and explaining to us the situations that your family has found itself in. But that was a very powerful account really of where misunderstanding the situation can cause havoc for people's lives. So I would, you know, when we're moving forward with all of these strategies, for me, the more case studies, if I can use that phrase, the better, because it really crystallizes everyone's understanding about the challenges that are faced. So thank you.
The only comment I would make with regards to going back to your Sarah Kelly baked cakes issue is certainly when I was talking to the young people last Friday, one of the issues they said, and I don't think it's necessarily confined to Herefordshire, it's something I've got to do a bit more research on, is the fact that the sort of work that they are taken out to, the training that they're given, mainly surrounds gardening, farming and cooking. And that isn't everybody's cup of tea. That isn't what everybody wants to be. And there was a lot of young adults there who were really, really clued in to the gaming industry, not just the playing of it, but the actual technical side of it, the animation side, the production of games, etc. And I really think in Herefordshire we've got an opportunity here, possibly at Rotherhurst or somewhere, to actually find some organisations that are involved in that sort of technical stuff to work with some of our young adults who've got autism, who have got particularly really, really good skills on that sort of industry. And I certainly am looking at, you know, ways of going forward with that. So that.
I just want to keep sort of reiterating that I know autism is a disability, but actually there are so many strengths. I mean, I'm a qualified accountant, and I was disadvantaged at school as well, especially being a female in my day. You know, there was no way they expected you to become an accountant. So because I was good at mathematics, spreadsheets, all of those things. And certainly in the gaming industry, there's one society up in Scotland where he set up a business because his son was disabled with autism. And they are superb because the attention to detail is phenomenal. And so from a gaming or any software, in fact, getting people to test and test and test, autistic people are superb at that. So any job where you want someone with really good concentration skills, yeah, an autistic person is actually good. And I do believe it's not HMRC, it's the government have got somewhere in Hereford, it's one of their businesses where they are looking, or were looking a few years ago when they opened up for autistic people, simply for the fact that they could actually keep looking through things all the time in a very clear and strong way. So there are so many advantages, especially with somebody like me, because I still do the work rather than the talk when I'm at work.
Thank you. And just note it. And thank you very much, Valerie. Thank you. Okay. Right. We go back to the agenda now. So we now move on to what was item 7, which is the update to the board on the Good Mental Health Action Plan and Mental Health Needs Assessment. And that is being presented by Kristen, I believe. Yes?
Thank you. Okay, so this paper is brought to the board to firstly provide an update on the progress of the implementation plan. So this is for the board's strategic priority of good mental well-being throughout the lifetime. So the implementation plan is attached as Appendix 1, and then we will lead on to the Herefordshire Needs Assessment, which my colleague Michael will cover. And the second ask is that we receive feedback on the outcomes dashboard, the report attached as Appendix 2 and the dashboard as Appendix 3. So, as previously brought to the board, Appendix 1, the implementation plan has continued to be updated alongside consultation with our partners. We have continued to identify activity and actions which contribute to the 4 high-level ambitions, as well as setting targets against these. There are still some areas which we will continue to focus on, but the implementation plan will continue to evolve and develop as we continue to engage with our relevant partnerships. Overall, we are making good progress with the implementation plan, with much of it progressing well. Some areas have minor delays, as highlighted Amber, and there has been one area with a slight concern. This has been our engagement around the children and young people's area of emotional health and wellbeing, due to the group not meeting recently. However, since the publication of this document, there has been progress made in this area, so it's not as high a concern. There are some new pieces of work coming through, highlighted on the implementation plan, including a suicide strategy refresh, which we aim to complete by spring next year. The monitoring of the progress of the plan and activity is being reported regularly back to the Adult Better Mental Health Partnership Board every 6 weeks. So in order to support the monitoring of the outcomes, we have also created the outcomes dashboard, which I mentioned as Appendix 3. We have drafted 47 indicators to measure each of the 4 high-level ambitions, and with the support of our partners, we will monitor these. We are keen to take any feedback if there is on these. The ongoing needs assessment that Michael is working on will feed into the action plan, and it will continue to support the development and focus our actions. I'm happy to take any questions, or I can hand over to Michael to talk about the needs assessment now.
Just a point I would like to raise. Under Ambition 4 and the promoting of volunteering opportunities, and the target review is December 2024. Yeah?
Just finding it. Yes, I find it.
Yeah. I think it's page 32.
Is that 4.21?
Yeah. That's obviously Amber, which is promoting volunteering opportunities available via Herefordshire Wellbeing Ambassadors and Strong Young Minds Champions. We're 6 months gone down the line now. I just wondered where you were with that. It just says exploring current offer. It doesn't really tell me very much.
Yeah, so again, there has been work with our partners who are leading on that piece of work. So we've been identifying what activity is planned, and the review date is December this year. Yeah, that's all the update I have on that one.
Right. Okay. Anybody else have any comments to make on this report? Yes.
Sorry, me again. It's just a question for me around access to mental health, and just to whether I know we are moving in the right direction with the kind of place-based mental health approach and across partners, but it's really whether we're really confident that we are addressing the population health approach to mental health and rather than organisation, because my worry around some of the actions is there will be organisation centric for some of those things, but if I talk you through my reason behind that is when people look to access services in whichever way they do, depending on which point they access, so certainly from general practice point of view, I feel ill-equipped to be able to tell them where to access the services, who's going to see them most quickly. Is it the VCS? Is it the trust? Is it which part of the system? And giving helping our communities make be able to make those to access the services that they require in the most effective way it can still be organisation centric. And I guess I want really more assurance that we're moving towards the population base. Well, actually, it's actually that front door shouldn't really matter. It's actually these are the services, and we're all working together, even if behind the scenes we may be working in different organisations. So I guess I just want to make sure that we're moving towards that, because it's really hard to understand what is out there. There are so many things that are available, and I actually, as a referrer, I have to remember all those things. I'm afraid my memory's not up to that. So I'm just conscious of just trying to make sure that we've nailed that with regards to bringing and joining that, so that they are truly integrated in the offer to our communities.
I think that's a really good point. I think some of that will be covered in Michael's presentation shortly, and also the ongoing needs assessment work, because this is kind of stage one. So definitely some of the service mapping, the understanding of the availability of local services is included in that work.
Thank you. Thank you for the opportunity to speak about this work today. I'm just going to share my screen. Yes. Yes. So my name is Michael DeLilly. I'm a public health registrar working with the public health team. So I'm just going to share this. Okay. So I'm going to take you through a piece of work that I'm leading, which is the Herefordshire Mental Health Needs Assessment. So first I thought I would start with the aim. So the aim is to review the mental health and well-being issues experienced by Herefordshire residents, map and engage with local providers and stakeholders, and produce recommendations that will support the improvement of health, prevention of illness, and reduction of inequalities. So, we're going about this in a process way. So the first, which is what I'll be presenting a bit of today, is reviewing and summarizing available data related to mental health and well-being, obtaining data from partners and identifying data gaps, meet with and survey stakeholders to map mental health support provision and gain insights on potential issues, obtain and review public health engagement data from stakeholders, produce insight summary, and finally some final recommendations. And as Kristen mentioned, the results of this work will iteratively feed back into the implementation plan and associated outcomes. So to go along with that process that I outlined, we have three proposed outputs. The first of which is an epidemiological profile, which this presentation will present some findings from. Following that is a mental health provision mapping, where we will try to map out the offer in terms of mental health care and support available from different organizations and partners in Herefordshire. And right now we actually have a stakeholder survey live that has gone out to these partners. And finally, an insights, engagement, and recommendations report, which also hopes to include some of the results from the ongoing Children and Young People Quality of Life survey that is also live at the moment. So there's a lot of exciting things going on right now. I've included this image because this is from a different local authority, and it's kind of one of the proposed outputs that would be great to have from the mental health provision mapping. So hopefully expect to see something similar for Herefordshire. In terms of the scope of the needs assessment, we're looking at conditions and mental health and well-being across the whole life course, and we're looking at problems and conditions of any severity. We're engaging with all stakeholders, so that includes care providers, VCS organizations, etc. And in terms of conditions or problems, we are excluding suicide because that is being covered by a separate strategy that's underway, and dementia as well, which we hope will also be covered separately in due time. So coming to the EPI profile specifically, this will cover children and young people as well as adults. For the purpose of today's presentation, I'm focusing on presenting the data from adults. And it's broken up into several sections. So for these different groups, we'll look at their mental health and indicators of that, health-related behavior data, individual determinants of health, and also data from at-risk groups. So these are particular groups where we believe mental health may be an area of concern. Of course, we will also consider the effects of the wider determinants of health on mental health and well-being, as illustrated in the very popular diagram to the right. also the potential effects of national and local policy, as well as new and emerging opportunities in our local area. So when I talk about the data that I'll be presenting shortly, that data comes from a variety of places. In terms of the indicator data, that is available publicly to anyone by accessing Fingertips, which is a website that's maintained by OHID, which is the Office for Health Improvements and Disparities. We also will be presenting data from residents, which we collect via local surveys. And finally, data that was shared with me from stakeholders for the purpose of this project. So what I've done is, as I'm sure a lot of you who are familiar with this data and look at it very often, you'll note that there's a lot of indicators that are related to mental health, especially when you consider health-related behaviors, individual and wider determinants of health, etc. And obviously, if you have this in a table, it ends up being a very, very long list. And sometimes it might be hard to understand which indicators might need more or less of our attention or are more interesting to focus on. So I've created these figures, as you can see here. At the center, where the two lines meet, or where the two axes cross, would be the England value that I would expect. So the further away strength of evidence is from 0, the more certain we are that we're different from the England average. And then in terms of the y-axis or the vertical axis, that says what percent difference we are from the England expected value. So for the purpose of ease, I've also used the similar RAG rating system where red is worse than England and green is better, yellow is similar. So for example, here we could see that compared to the national average, we have less premature mortality related to severe mental illness, and also lower prevalence compared to the national average, and also less secondary mental health inpatient stays as examples. One area where we struggle compared to nationally, although the percent difference is small, is we have less community and outpatient mental health attendance to expected appointments. So this is kind of the national comparative data we have for mental health indicators for adults. If we move on to health behavior indicators, so these are health behaviors that are either protective or often risky in terms of poor mental health and well-being. Here what we see is with respect to alcohol admissions, we are better than the national average. So you see alcohol admissions has different metrics. So some of them are alcohol specific, or alcohol narrow or related. And also we have lower levels of alcohol dependency. However, we do have what seems to be some persistent smokers. So we, compared to national average, we have less smokers setting quit dates among those people who are still smoking, and less of those smokers who are still quit at 4 weeks. However, you might notice the eagle-eyed among you that we are slightly below the national average for smoking prevalence, as some of you might know. The also eagle-eyed among you will see in the top right corner, we do have another red indicator, and that's road traffic, collisions, casualties associated with those, where there was a failed breath test. So if we look at individual and wider determinants of health, again, some of this won't come as a surprise. So compared to national expected values, we have lower rates of unemployment, violent crime. However, we do have a higher percent of fuel poverty and long-term health problems or conditions and obesity as well. Although there are different estimates of obesity which suggest that we might be closer to the national average. Finally, at-risk groups. The interesting thing here is that when you come to be able to see the whole document, you'll note that we've identified a lot of potential at-risk groups for mental health and well-being. However, in terms of what data is collected at a national and regional level, where a national comparison is possible, this data is actually very limited. So as you can see here, we have quite a few green indicators. So for example, households in temporary accommodation. However, we do have some that are red as well. So adults with learning disabilities who are in appropriate accommodation, or households older duty under the Homelessness Act, for example, are areas that we struggle compared with national values. So what I'd like to move on to is what I think is some of our most valuable data, and that's data that we collect from surveys that are delivered by the council and the local authority. That's because, as you can see, looking at the national data that was presented in the indicator graphs, there's quite a lot that's missing as well. So for everything that we know, there's a lot that we don't, and some of it's quite important. So for example, ratings of well-being, some things like quality of sleep, loneliness, and these are things and topics that are covered in the recent community well-being survey that was delivered. So I'm just going to present some of this data now. You'll also notice that there's data both for 2023 and 2021. That's because the survey has been delivered twice. So what was really useful is they were able to compare it to the 2021 results to see how it's changed over 2 years. Of course, bearing in mind 2021 was during the COVID-19 pandemic. So in terms of activities, people were asked if they're doing activities the same, more or less than they used to before the pandemic. And what you see is a lot of people were returning to kind of pre-pandemic levels of their activities, which is positive. However, what's really interesting with the survey is there's a lot of questions that are asked, which include survey questions related to demographic characteristics or more kind of understanding more about the person and their circumstances. And that helps us understand who might be struggling more for certain areas. So for example, if we look at those people who might have reported that they sleep well less often compared to before the pandemic, what we find is that these people also come from more deprived areas, might be renting from a housing association or trust, might report that they have no formal qualifications, report having only poor or fair health. They also report feeling lonely and have low mental well-being levels. So having this data and this information about them allows us to kind of connect the dots and understand what might be driving poor mental health and well-being. Again, like I mentioned, actually nationally, we don't have very good measurement of well-being. They do really well at a national level, but not at a regional level. So fortunately, the survey lets us measure this at Herefordshire level. So here they were asked to answer several questions about their well-being that were combined to create an index score. And on that score, you'll see that about 1/3 of people report good well-being, just over half moderate well-being, and almost 1 in 10 report poor well-being. But on the whole, mostly positive, so good or moderate. For those people with poor well-being, we found that well-being levels decreased significantly amongst those living in the most deprived communities, those renting from a housing association or trust, and people living with a disability. Interestingly, we saw that well-being levels notably increase among people who owned the homes that they were living in. And again, you can see some of the individual data in the figure. If we move on to loneliness, so more than half said that they've never or hardly ever felt lonely. 20%, so about 1 in 5, say that they occasionally feel lonely. This actually went up since 2021, interestingly. And 6% reported that they often or always felt lonely. Again, where we take a closer look at who these people are and what are some of their characteristics, we see again that it's people who report having no formal qualifications, people with a disability, people who are mature independents, and also who have low mental well-being levels. So they were also asked to rate their anxiety on a scale from 0 to 10 with respect to how anxious they felt yesterday. So comparing 2023 to 2021, 61% had a similar level of anxiety, 22% said they had higher anxiety, and in general, about 1 in 4 people reported having high anxiety. When we look at who are those people who report having high anxiety, we find that there are people who report being from an ethnic minority, people living with a disability, carers, and people with young families. So if we move on to the at-risk groups, as I mentioned before, in terms of what's collected nationally, there's very little data from the at-risk groups that's helpful. So we have to rely on stakeholder data here. So these are this data largely came from data requests that we got from our care providers, VCS organizations, etc. And I'm just going to summarize and highlight some of the data and issues that came up. So the first is around data availability and accessibility issues. So just to give an example, if we're trying to get some data for at-risk groups from our care providers in terms of, let's say, primary or secondary care, some of the data systems might not capture some of the characteristics or some of the information we need in a routine way that makes it very easy to access that data. So for example, if we wanted to know information about people from the GRT community, so Gypsy Roma Traveler community, That might be difficult if ethnicity isn't coded in such a way that those people could be identified from a data set. In terms of what data we did find for some of our at-risk groups, we believe that older adults may potentially be underrepresented among patients who are accessing care and support for their mental health and well-being. So if we look at what we expect to be the rate of older adults who might need help with a mental health problem or condition, and we see how many people are accessing treatment, this looks like there may be an important number of people who are experiencing problems who are not accessing treatment. So this is something that we might want to consider looking at. In terms of carers, there's a great work being done with the carer strategy that the council is launching soon. However, as we know, carers are very difficult to quantify, and we do have evidence that they do have worse well-being compared to people who don't have caring responsibilities. So neurodiverse adults, in a way, it was really good that we covered the all-age autism strategy first, because it's a really nice example of a really good piece of work that's being done in this area. However, we do know that there's unmet demand for assessments and support as well. So there's a lot of peer support groups that are very popular, for example, that fill up very quickly. So there's maybe more that could be done there. I think it's really important to highlight, when we're talking about a lot of our at-risk groups, there's a lack of recent local data. So this includes, for example, migrants and refugees, the Gypsy Roma traveler community, and homeless and rough sleepers. It's important to highlight as well that some data sometimes is only available at Herefordshire and Worcestershire level, because that's the fingerprint or the patch, the footprint, across where our integrated care system and board work across. But obviously it's very difficult to use data across the whole region, where really we need Herefordshire specific data to be able to best plan and make decisions, plan services, etc. So just to summarize, it's really important to note that most Herefordshire adults enjoy good mental health and well-being. However, there are a number of individual and wider determinants that risk worsening their mental health. And we do find elevated rates of some health risk behaviors that persist locally. So for example, among those people who are still smoking, they may be struggling to quit. And very importantly, little is known about the health and well-being of some at-risk groups. So it'd really be important to gain more insight there. So accordingly, I've just proposed the following recommendations just based on the EPI profile alone. So the first is to consider new opportunities to proactively integrate support for mental health and well-being. So what I mean here is the council have been really proactive and really supportive in terms of things like the cost of living crisis, fuel poverty, etc. And we should consider perhaps that when residents reach out to have support on these other areas, that we take an opportunity to check in on their mental health and well-being. So approaches that could be used are things like make every contact count and advocating for the 5 ways to well-being. Another recommendation is to continue supporting the delivery of local surveys to collect rich mental health and well-being data and to address knowledge gaps. So hopefully I've done a good job sharing some of the insights from the community and well-being survey. And of course, I've mentioned where there's some groups and some things we just don't have very much information about. So these bespoke, tailored surveys are a really good opportunity to plug those gaps where otherwise we wouldn't have any data. Of course, we want to continue strengthening our collaborative working with stakeholders to develop new strategies and facilitate data sharing and analyses. So, like for example, working with the ICB and our other stakeholders to in their new strategy development, and being able to kind of broker connections and relationships to be able to access data in a timely way. And finally, engage with people from at-risk groups and relevant stakeholders to plan how best to address identified unmet needs. So again, a great example is the work being done with the all-age autism strategy there. So that is all for me. Thank you.
Thank you. Any questions?
Yeah, thanks, Michael. Lots of whizzy stats in there, so very informative. And I guess it's just iterating to the board. This is kind of one part of a staged process in terms of reviewing the mental health needs of our communities. So obviously, what we really want to do is get that voice now of our communities, those hard to reach groups, to really understand what are those issues facing. And I guess it's a so what question with this information, isn't it? It's okay, so lots of data, but what do we do with it as a board? And we need to flex the mental health action plan to make sure it does pick up and address those issues which the needs and those communities are telling us. So it's just a really good piece of work, but it's part of a kind of an iterative process, I think. And I think over the next few months, there'll be a fuller picture in terms of what those needs are. And I think, as I say, it's just really important that the board oversee and make sure the Better Mental Health Partnership address those gaps that are identified. So, but thank you, good piece of work.
Yes, Mike.
Thank you again. Echo what Matt said. I'm just picking up my question earlier. I still think we do need to have something on access. I think it'd be really good to understand the data around the access and look at that in the same way you've looked at the detail, but I'm not sure we've kind of nailed that element of it, and it would be really helpful to work that through as part of the whole project if it's possible.
The only points I wanted to just make, which I recognise that you were looking at 2023, you talked about the fact, I think, if I got this right, that we've got above average number of people in who are rough sleepers, etc., etc. I think that's what your figures were showing. I think.
So for most of the homelessness and rough sleeping
It's difficult to see, but I think that's
outcomes,
and homelessness.
there was just one where it's households owe the duty under the Homelessness Act. But in terms of households in temporary accommodation, we're better than national average. Households are not homelessness, not priority need. It's also better than national averages. So yeah, it was just in part that one area in particular.
Right. Because we have got a significant number of people in temporary accommodation for the population we've got, and we might be above, we might be below the national average, but I would suspect if we are not in that position with our statistical neighbours necessarily. And we have done a lot of work with homelessness people, so I think we've done a lot of work around that, and mental health, and trying to get them to supported accommodation as well. And I think that I think the board needs to recognise the amount of work that we've done around that. I may be wrong, but my understanding is that certainly at the end of beginning of June, when we closed the shelter for our homeless people, our rough sleepers, we would at that stage, and that will have probably changed now, we only had actually 3 rough sleepers that were still actually sleeping rough on the streets, which I think compared to probably most local authorities is a very small number.
What it is important to mention with this data, I do have it in the document, but some of the data is quite delayed when it's reporting, so often it will be some data is more old than others, but sometimes it could be at least a year or more. But that'll be more clear in the document.
I do think it's important to recognise that both the council and the voluntary sector have worked really, really hard over the winter months and the spring to get as many of our rough sleepers into supported accommodation and deal with the issues that they may have in order to stop them being rough sleepers. We can't eradicate it, but we have done amazing work around that to get the numbers down to what is a really low level now.
Yeah, can I just check my understanding of some of the smoking ones you talked about there? So there were a couple of indicators down in the bottom left corner, red, smoking quitters, but prevalence was about the national average. So I think there's a question about how does that compare to statistical neighbours, which would be interesting because Herefordshire's not typical of the national average, is it? But it would be similar to other kind of rural areas. But I guess my specific question is, were those red indicators specific to people who have mental health conditions?
No.
No. Do we know smoking quit rates amongst people who have specific mental health conditions? Because we've put quite a lot of effort into stop smoking activities for people with mental health conditions. It's quite a complex thing, isn't it? Because when they come into mental health services, trying to encourage them to stop smoking is possibly not the best time to encourage them to stop smoking. So it's a kind of a longer term activity. So I'd be really keen to understand that a little bit more through this needs assessment.
No, it's really important because, as you know, it is a group where smoking is quite persistent as well. But no, this data isn't in relation to that, but that is something I could try to look into to see if I can find that data. That'd be great. Thank you.
Yeah, a couple of points, thank you. And obviously we had an opportunity to look at this last week. So that was helpful because I thought that data was specific to people with mental health issues and smoking. So it was a more generic.
Yes, yes.
Okay. That's helpful, but of course that also relates back because that's sort of specific around whether you've been able to quit or not, and some of that is related to your prevalence in the first place, isn't it? You're down to the
Yes, that's
to the
right.
hardcore, if
That's
you,
right.
if
Yes.
you like. So, so all of this has a context, doesn't it? But I guess as part of that context, I mean, a load of these indicators are, whilst the whole of our national averages are a deteriorating picture with mental health in many ways, it's a good news picture for us, isn't it? I mean, most of those indicators are in the same as elsewhere or significantly better.
Yes.
Are you going to cover the dashboard, or is that just there for information? I mean, particularly want to go through it in detail, but just checking whether you were going to cover it as part of your presentation.
No, but Kristen might be able to answer questions about it.
That's fine. It was just to bring out the discussion that we had. Yeah, there are two issues really. One was that the dashboards needed to include the things that Mike was talking about, which is actually some of those access rates and statutory services sort of need to be on the dashboard and the waiting times and things. And the other was there are some red areas. I know you're doing some more work on whether they should be red or not, which is the right thing. But it feels that those things, when we look at this again, need to then have a specific action about them. If we continue to be worried about hospital admissions for 10 to 14-year-olds with self-harm, then we need so what are we doing about it? It's the so what question. And the other thing, of course, is on that dashboard there's a number of things that are really very out of date, and that isn't your fault, but where things are 3 years out of date, it's quite difficult to draw anything particularly from that, because the world's moved on in the last 3 years. But I think it's a really positive piece of work, and the needs analysis to feed the next iteration of the plan, and are we putting our resources into the areas where there's the biggest problems, is the next piece of work we need to do, isn't it?
Kevin, did you have your hand up? Yes.
Sorry, Chair, I did. Again, it's about the dashboard. It may be something I can get briefed outside the meeting, Chair, but I don't always understand what proportion is referring to in some of the data, whether it's the whole adult population. So I'm not sure what the baseline is on some of the measures. But from the safeguarding point of view, a bit concerned about the self-harm figure as well. So I think I'll be taking that away to the Children's Safeguarding Board and asking what's behind that. So going to Matt's question, what do you do with the data? There's a couple of questions certainly for me from the data within this report. Let's say might benefit a little bit by more definition of what proportion of what.
I think there's another one as also with the estimated dementia diagnosis, which is red. But really and truly, it's only red because it's higher than our statistical neighbour. In every other area, it's much better. And I think I understand what you're saying, but it's our nearest neighbour. It's lower than the England rate. It's lower than the region rate, but it just happens to be higher than our nearest neighbour that has a low rate. And I don't know whether that makes it red.
I mean, I'll come in on some of these. I mean, I think some of the targets are arbitrary. So some are red because they're lower than the national average. Some are red because there might be a national target and we're lower. I think what we just need to be careful of is sometimes we might be green, but actually it still might impact on a significant number of people as well. So I guess there's something about how we just interrogate this data a little bit and be clear in terms of what that's telling us. But it is something for the board, I think, to look at this regularly. Every 6 months we're going to come back to this, aren't we, and looking at that. But I don't know if you have a specific point, Michael, on there. Or can you answer dementia diagnosis question,
Yeah,
David?
that's an indicator where it's better to be high. So it's better to have a high number. So the fact we're 59, we're below 63, we're below 71, we want to be up as high as possible, not as low as possible.
I'm looking at the one that's 53.
Yeah,
Yeah.
but it's better for that number to be high, not low. So it's low because it's high, it's red because it's lower than the other numbers, not higher than the other numbers. Because it's about finding people with dementia, so we're then able to treat them.
But really, it's very subjective, isn't it?
It's a very recognised measure, though, in that we're held to account to as a local system about finding people who have dementia and then being able to treat them with it.
Right. Okay.
It's one of our high priority areas for improvement this year.
Okay.
Just in case, because it was quite technical, that answer, just in case people hadn't understood it. So statistically, there is a number of people who should be diagnosed with dementia, because it's very likely in our population they have dementia, and the fact is we haven't found them, and so we are seeking to find and diagnose everybody with dementia so that we can then treat them. So this isn't we've got a low rate of dementia. We've got a low rate of finding the people who we would expect to have dementia, just given our demographics.
I understand that.
Yeah. So just in case for others they hadn't understood what that conversation was
about. Doesn't that apply to a lot
about.
of these things? That there are a lot. For example, the smoking. We don't really know, do we? How many people there are out there that are still smoking? It's only a guesstimate.
So some of them do, but I think it's quite heavily based on evidence, isn't it?
There's lots of estimates. It's normally, we get quite technical now, it's normally based on sample sizes, and they extrapolate that and generalise it to local areas. So, like you say, there's lots of technical queries about what we really know is the estimated dementia rate in Herefordshire, and there's some queries around that, but it's I hate to use the word the best guess, but we have to kind of use something to try and set a target for which we want to achieve. But yeah, we are where we are with that, and that's been a long-standing issue, I think, in Herefordshire. But they have made some progress. I think it is improving, but very slowly, is my understanding.
It's just a general observation in terms of the action plan is very heavy actions in terms of responsible statutory services, but there's a lot going on that's not necessarily captured. I know the stakeholder mapping is on the things to do list, but some of the more obvious sector like mind and things like that are making a positive contribution in this space, but some less obvious, like men in sheds, is very preventative. So it's finding a way to capture the value, the added value that the voluntary sector are contributing in this space, because it's not all down just to the statutory services. There's a lot going on. So I haven't necessarily got a solution in my head, but it's finding a way in future versions of this to capture the whole picture and not just the statutory services. Does that make sense?
Yeah.
Thank you.
So any response to that?
I think that's a really useful point, and I think this is like the second iteration of the document, so it will continue to evolve, but yeah, we're definitely still looking to work with our partners and include all of the great work they're doing.
That's up for the board to decide if they want to
Wish to take those
combine.
recommendations on board? Do you want to put the recommendations up again, Mike?
sorry about that. We have an approach that I think already is being used quite a bit around making every contact count. And of course, also, we do a lot of work around promoting the 5 ways to well-being. And the suggestion around recommendation 1 is that when people might be engaging with the council to receive support for a variety of things, for example, cost of living, fuel poverty, etc., that those might be opportunities to use an approach, for example, like make every contact count to check in with their mental health and well-being, to see whether there might be some support or signposting that would be appropriate in those instances.
I'm a little bit nervous about that one, I have to say, because if someone comes for financial support, I don't know what other members of the council talk about this and council officers, but Matt.
Yeah, can I just come in? So generally what happens with I'm not sure these recommendations for the board themselves, but I think it's more about from the health needs assessment, these are the initial recommendations in terms of what we should embed within the next iteration of the action plan.
Okay.
So when the action plan comes back in 6 months' time, these recommendations should be built in, of which the board then ratify. And actually, it's the collective responsibility of all of us to play our part. It's not just the council, so we kind of agree on behalf of our organisations. That's probably what I would suggest. Is that right,
Yeah.
Michael? Sorry.
That sounds fine. That sounds fine. Okay.
Thank you, Chair. So I'm going to take you through some of the key points of the report, and then I'm going to hand over to Adrian to go through the financial aspects, if that's okay. So the year-end template requires confirmation that the BCF national conditions continue to be met throughout the year, and confirmation also of the actual income and expenditure against the BCF Section 75 agreements within the 23-24 year. And that covers the whole of the Better Care Fund plan, including the Adult Social Care Discharge Fund monies. The report also requires us to detail any successes and challenges during the year, and as board will be aware from previous rounds of this, there's always a really relatively short window of time between NHSE publishing the reporting templates and the national submission deadline. So the deadline again for this year for the return has already passed on the 22nd of May, and our reporting cycles aren't quite in line with the national requirements. Therefore, the board is requested to note the content of the report and retrospectively approve the end of year report. I'm pleased to say, though, that Herefordshire has reported that all the national conditions as listed in the document have been met, but we do have a few indicators where performance and monitoring identifies that there are a few indicators that are not quite on track to achieve what we'd hoped within the last year. So we are below target in relation to avoidable admissions, that's non-elective admissions at year end, showing 212 against a target of 151. In this case, a lower number of admissions is better for the target. This has been linked to activity growth in urgent and emergency care, which has contributed to the increase in unplanned admissions, with high levels of activity being supported by community teams and continue to carry on that support to try and reduce admissions. The percentage of people who are discharged from the acute hospital to their normal place of residence was at 91% against a target of 91.4%, so we were just short of that. At the beginning of this year, there was some initial challenges with discharge to assess pathways. However, we have improved the position over the year with developments in terms of working as a system together to address these. So you may recall that in April of last year we had significant delays for Pathway 1 in terms of discharges to home care providers, and the All Age Commissioning Service have been working really closely with providers to develop the framework and increase the capacity on the home care, and we have seen that increased capacity come through for both discharge to assess and the community referrals, so significant pieces of work there throughout the year, but we did start off the year with some challenges in relation to that. We also have been undertaking a range of process changes as well, and looking at the pathways and ensuring the right therapeutic input at the various stages to ensure that reablement capacity is available for those who need it across all 3 pathways. So continuing to improve there. Emergency hospital admissions due to falls in people 65 and over showed a full year figure at the end of 23-24 of 1696, and the target was 1372. Therefore, this was not met. Recruitment into therapy posts has been one of the key challenges, and this continues to be difficult, and successful recruitment in this area would see a shorter wait time for falls and fall prevention clinics. So work and plans around that workforce challenge continue to be put in place and built on to encourage the recruitment. The Community Integrated Response Hub, known locally as CIRA, and the Urgency Community Response Team services are now linked into the Falls Responder Service as well, so we're continuing that joint working to try and improve this measure. And we also reported as not being on track to meet the target in relation to the number of permanent admissions to residential care, reporting 484 against a target of 521.6 per 100,000 population. So although we didn't meet the target, this has remained fairly static in relation to previous years, with a 0.77% increase from last year. Again, as I've mentioned, there were challenges at the beginning of the year due to the capacity in the home care market, which meant that we were using beds for people who we couldn't access care in a timely way for. So that has impacted on the figure this year. But we do still see in Herefordshire a high number of people requiring pathway 2 or 3 beds, so that discharge into the care home market. The care home market is vibrant in Herefordshire, so we do have capacity within the market to offer care, but the challenge that we face is that care is often not at or close to the council rate, so the cost of care continues to be a challenge in Herefordshire. But this year we have been working on a system-wide review of our D2A pathways, and as I mentioned, the changes to the therapy services, so that we are making sure that people are going into the right pathway at the right time. So we're discharging more people into pathway 1 to try and reduce that impact there. On a positive note, in terms of our key achievements, we continue to have a strong system approach and utilise the One Herefordshire Forum to work with all partners, and that forum provides governance and leadership to the system. But we've had some key successes this year. So the Better Care Fund has enabled the creation of a bridging team within the community, the CIRA service, and organisations have worked really closely together to embed a process where patients could be discharged to their usual place of residence while waiting for reablement capacity. This has enabled the system to ensure that patients' needs were met during that period of time. We have also seen the creation of our Discharge to Assess board, which is a board that meets regularly now on a monthly basis across the system with all partners represented, and that's jointly chaired between Health and Social Care and Health. That's enabled system partners to work together on a jointly agreed improvement plan for Discharge to Assess. That's also seen the introduction of a data analyst post to focus specifically on Discharge to Assess. As reported last year, we've had some significant challenges with accurate data around our Discharge to Assess services, and we are in a position where we're moving to our first dashboard for Discharge to Assess, which has accurate data, pulling that from the council, Wye Valley, and our service providers such as Hoople. So that's been a really positive move. There's been a significant amount of work in improving our Home First capacity and our Home First service delivery. So we've worked very closely with Hoople to make amendments to rotas and posts, etc., which has seen a significant increase in hours provided by our Home First service, ensuring that we have timely discharge, and that work is now coming to fruition, and we're seeing much better pickup from Home First. That is enabling us to start to see a reduction also in the use of spot purchase beds, because alongside the Home First service, we've been doing work with our Hillside service, which is our Pathway 2 residential facility for discharge to assess. And we are working together to ensure better triage at discharge, so as people get to the right care first time, and that's really starting to show some improvements. And during the winter period, we worked across the system to utilise additional urgent emergency care funding to develop a range of block booked care homes beds within residential and nursing settings, so as that we could ensure really timely discharges with that increase in capacity needed from January to March of this year. And that really supported the demand across the winter. The beds were really well utilised, and that supported an additional 29 discharges within a timely manner. So I'll hand over to Adrian now just to take you through the finance elements of the end of year report.
Thank you, Hayley. So on a finance basis, essentially each pool or each fund of the Better Care Fund is in itself a funding stream, which is therefore limited based on national allocation. So the fund has to balance back to each funding stream. This year, the funds overall overspent slightly, less than 1% against a budget of 29 million. That overspend was expected. It came down towards the end of the year, which was also planned for. So the two statutory partners, the ICB and the council, the risk sharing agreement in the section 75 between them is that there's different responsibility for each pool, but essentially they make good the overspend. But that was planned for and covered. Hayley's already spoken about the challenges of costs in the care market, and that certainly led to much of the overspending on both social care discharge funding, and we also, recognising the costs of discharge that we were buying, we had planned to use all of the accumulated reserves from underspends in previous years for the Better Care Fund to cover the cost of the discharge system for 23-24, and we did that. For 24-25, obviously means that reserve doesn't exist anymore, but Hayley's already spoken in some detail there about the improvements that we've already made in the discharge system, and we have completed the 24-25 Better Care Fund plan refresh, which has been submitted today, because once again the timings don't mesh with Health and Wellbeing Board, unfortunately, so we'll talk about that in more detail at the next meeting of this board. But we have a balanced plan, and the demand and capacity plan for discharge services. We have planned for a continued improvement in both occupancy and length of stay within the services, so that we further reduce the amount of care that we buy in the market, making the system both better integrated, more responsive, better for patients, but also more affordable, more sustainable for us. I'll stop there because I won't go into the detail of every pool. I could be here all day.
Do you want to say something?
Yeah, just a couple of comments. So the first one is to say this is an area of really great partnership work, and I think the changes we've seen over the last particularly 6 months have been really impressive, and I think things have moved on really well. Of all of those indicators that are in there, I guess the one that I'm worried about most is the 91 days performance being at home 91 days after a reablement service. So I think the work that's being done both on the capacity, but I think also the capability and the quality of reablement is something that I would expect to see this measure move over the course of the year, and then that in a sense then makes a difference to sort of some of the other areas as well. So some of that number of patients going into residential care, hopefully if we can get this right, then we reduce that number as well. So I think that's a core indicator for me, which will impact on a number of other ones. So so I think that's in a way my biggest worry, but it's also the biggest opportunity that we've got, and the teams are working really hard on it.
Thanks.
You might not be able to answer this question, but the one that struck me was the falls, the emergency admissions for falls. Do we know whether that's because of an increase in the number of people that are falling, or just an increase or an inability of us in the NHS to be able to prevent them being admitted once they arrive? Obviously, if somebody falls and has a hip fracture, it's clearly they're going to go into hospital, they're going to have an operation. But not everybody who falls has a kind of traumatic injury. And that number's quite a lot higher, isn't it? 1,600 or so admissions against a target of 1,300. That's quite a gap there. I'd like to understand that a little bit more, if possible, because we're doing some work on falls in the ICB at the moment and looking at how we can try and improve that.
You want me to try to answer that, Haley?
I think Matt was just going to come in, Adrian,
All right.
and bring you in.
Well,
Then I'll bring you in if that's okay.
Well, I don't have an answer, but I know a colleague in my team, Harpold, is doing a falls needs assessment at the moment. So I wonder if that might be born out of that work. But I don't know if anyone else has anything addition to say. But certainly something we can look at, David. I think it's a good point.
Adrian, do you want to just?
Yeah, just briefly, it's worth noting that whilst the number of falls per head of population increased for 23-24 compared to the previous year, in the public health outcomes framework as a county, we still benchmark very favourably nationally. I think we're still in the upper quartile for performance in terms of we have a relatively low number of falls for our relatively high number of older adults. It's also true in terms of people who fall but don't need to be conveyed to hospital. We have a falls first response service that's provided by Connexus that covers an awful lot of that demand. So a lot of ambulance call-outs for people who don't need to be taken to hospital are avoided because of that service. And Connexus also provide a falls care navigator service where they pick up people who've had frequent falls or have made frequent use of the falls first response service and work with them to signpost them to appropriate services to reduce the amount of falls they have in the future, which also shows a reduced number of falls for the individuals that use that service. So we do have some services at the moment that do contribute to not to stopping people falling, but to them having subsequent falls or them going to hospital when they don't need to.
Yeah, I recognise what Adrian's saying there. I guess my concern is that the public health data set, the fingertips data, is a couple of years old at least, possibly 3 years old in this area on falls. It's certainly not 23-24 data. And if this is one of those ones where we've seen an increase recently, we want to try and act quite quickly upon it now and not kind of think to ourselves that we're safe in this area because data from 2 or 3 years ago was good. That's my point.
Do we know whether organisations like Talk Community, etc., do work with residents around falls about rugs and proper slippers and all that sort of thing?
I think that's what the falls assessment's trying to establish really, is what is the need and what is the current provision that we're doing. So I'm sure Talk Community is doing some things. We did have an array of strength and balanced exercise classes. I don't think they're as comprehensive as we maybe want them to be. I think the community element is something probably where there needs to be a lot more work. I've actually covered it in my DPH report briefly later, but I think that's something, I think it was down on the forward plan actually, Henry, to bring it here. I'm not sure if it still is the falls needs assessment. That could certainly be an action out of this to come back with that.
Whether we need to be doing sort of some promotional work around, falls and around the fact that not having rugs in the house and wearing the right sort of slippers and because that they're fairly simple things that people can do that can avoid falls.
And we have our fire colleagues here today as well, and I think
Yeah.
there's opportunities elsewhere in
There's
the
op- yeah,
country
there
that
are.
they've done during their
So,
warm
so
and well
when,
visits.
when you go into properties and you see people with sort of slip rugs on the mat, on the floor and things like that, and flip-floppy slippers and mules and things, do you?
It's all part of our home fire safety check process, yeah. So we have the opportunity to do that, but we're also providing access and egress for our other emergency partners in order to get into people's homes should there be an issue.
Okay, so I need a proposer and a seconder to the recommendations, and that's it really. So I propose the report as read. Do I have a seconder?
Second for you.
All those in favour? Any against? No. So we move on to item 9, which is the Director of Public Health Annual Report. Before I ask Matt to present this, I'd like to thank Matt on behalf of the Health and Wellbeing Board for all of the work that he's done over the last few years that he's worked at Herefordshire Council, not just for the Health and Wellbeing Board, but in other parts of the council and out there in the community as well. I wish you well in your new venture. I believe that we've got a temporary sort of interim Director of Public Health coming in place very shortly. I just on the behalf of the board wish you all the best. Thank you. We didn't bring you a cake. In fact, there was a long discussion about whether we should be bringing the cake or you should. And your colleagues, I have to say, said they thought you should.
That's very, very kind of you, Chair, and thank you. And yeah, it's been an absolute privilege representing Herefordshire Council, and I think there's some fantastic things going on. Public health, often we talk about all the things that are going wrong and all the problems, and I think that's been evident today, but clearly there's some really fantastic things and great assets in Herefordshire, so hopefully leaving it in a really strong place going forward. So thank you all, and it's been a pleasure to be part of this board. And it's been, I guess, a good opportunity to maybe just finish with my second annual report for Herefordshire Council. So this is Director of Public Health Annual Report, and we have a statutory requirement as Directors of Public Health to bring annual reports to the board each year. And I think it's been a tradition since 1988. So it's very much an independent assessment of the health of the county, and that's one of the privileges we have of Directors of Public Health. So you'll all have the report in your pack. And I've just got some few slides to go through. I know many of you be familiar with ageing well and the challenges we face. And one of the reasons I wanted to focus on ageing well is very much because we all recognise the challenges facing children and young people in Herefordshire Council at the moment. That gets lots of attention and quite rightly so. But clearly we have a lot of challenges facing the county as a whole with the ageing demographic. And that's the same probably for the country too. So that was really the reason for the report, is to bring attention to the needs of older people. That said, you know, ageing is a positive thing and it's a positive experience, and I think I really want to make that point. It's not all doom and gloom. And, you know, ageing and getting older, they can contribute a lot to society, both as individuals, whether that's through volunteering, intergenerational knowledge and family values and those kind of things. I really want to make that point, that older people aren't necessarily a burden. They have lots to offer too, and I think that's really important to get that point across. So I have got a few slides. It's really just to bring out the key points from the report, and then I'll just cover my recommendations at the end. So we know the population of Herefordshire is rising in terms of the proportion of people aged 65. I said that's really good. People are living longer, but one of the downside of that actually is not always those years are in good health, which I'll come on to in a minute. And it's a collective responsibility that we all have a role to play, every member of this board and our communities and individuals, that residents do live independent, healthy and purposeful and connected lives. And connected lives is something really close to my heart. I know Christine and the work, the community paradigm work, is how we connect with one another. That's so critical in terms of how well we live our lives. But one of the things that's really important, which I wanted to get across, is that actually the development of ill health isn't inevitable as we get older. So as we get older, as I'll go on to talk about, we might experience and develop long-term conditions. Most people think that this is part of the aging process, and actually it's not. There are lots of things we can do to prevent and reduce the risk of long-term conditions, whether that's cardiovascular disease, hypertension, even cancer and things like that. So all the demands and pressures we're getting on the health and social care system, there's very much lots we can do, both as a local authority and our wider partners. So the next slide just really illustrates the population change that we're doing. So what I really want to do in this report is look at those demographic changes that we see, not just now, but in the future over the next few years, and what that might mean, and how we might need to change how we live and work and support older people. So the older population has grown over the last few years quite significantly, and this is going to continue. And it's about a quarter of our population over the age of 65. And we know that Herefordshire, mainly a lot of people come to live and retire in Herefordshire, so that's one of the driving changes as well. But obviously people just living longer through medical advances and technology and things like that. But we think that trend is going to continue with a 34% increase between 2018 and 2040. And you can just see those two maps on that slide. The light blue, 21 to 25% of the population being over 65, and to over 30% is that dark blue. And you can see that shift really, apart from the centre of Herefordshire. A lot of those rural areas, we're going to see around a third of the population over 65. So they're going to have quite different health needs in that population, and we're going to have to think about how we provide services in a different way. Quite small, this one, and you're probably tired of me talking about this, but it is about the life expectancy. You know, really positively, Herefordshire has higher life expectancy, so we are seeing people that live older and generally longer than the general population. That's great. 80 years for males and 83 years for females, and that compared to 78 years for England and 82 for England. So we're living longer. However, we know that actually in the most deprived parts of our communities, there is that gap of 5.2 years in males and 3.9 years in females. So that's something that as a health and wellbeing board, I know you're acutely aware of, and something we really need to support. I think the thing we don't often talk about is this healthy life expectancy. So actually, you know, those years is a subjective measurement, but actually how people report and you know, are they able to do the things they want to do. And actually for men, that's 64.2 years and 66.3 years. So actually there's a kind of a gap of 16 years for men and women, where actually they're not spending their lives in good health. They might have a long-term condition, they might not be able to do the things they do. And that's a big gap, and that's replicated across the whole of the country. So it's not always fair to think about how long we live, but how many of those years are in good health is a really important measure. And we know that's, again, correlated with affluence and deprivation. The other thing we did is look at long-term conditions. And long-term conditions, again, they're not inevitable. It's a combination of genetics, society, culture, environment, about whether people do develop long-term conditions. But they are and can be prevented. And absolutely, you can reduce your risk of developing a long-term condition. And what we know is about 50% of GP appointments are for people with a long-term condition. So again, you use up a lot of NHS resources. I think 64% of all outpatients are people with long-term conditions, and 70% of all inpatients. So, I think it's about 70p in every £1 spent on health and social care goes on supporting people with long-term conditions, of which we know we can do a lot about. And this diagram here just talks a bit about the kind of the main kind of conditions in Herefordshire. This is taken from GP practice data. So of those aged over 65 in Herefordshire, 50% have hypertension. So that's high blood pressure. And again, we know that significant things we can do to reduce that risk of high blood pressure. So that's a significant proportion of people. So that's and we know 1 in 4 in 35-year-olds have a long-term condition as well. So actually there's lots of work we can do even further upstream to prevent people. The diagram on the right-hand side, I've used this a lot actually in a lot of places I work, or actually it's quite hard to work out there, but there's an increasing issue around multi-morbidity, so people having more than one long-term condition. And if you have a look, that green dotted line I've just put on the diagram there, it kind of just illustrates that over the age of 60, 50% of people have one or more long-term conditions, so 1 in 2 people. And then as obviously you get older, you know, you're more likely to have a higher number of long-term conditions. So it's clearly a challenge for us as health and social care commissioners about how we kind of encourage people to live healthy. And then we just try to do a bit of projections really. So I think, you know, these are quite crude projections. What we've kind to do is map the current prevalence, so the proportion of people with specific long-term conditions, in this case hypertension, diabetes, chronic kidney disease and cancer, and we kind of map that prevalence onto the future population growth to kind of see what that looks like. And in that chart there you can see those individuals with hypertension going to increase significantly from around 25,000 to in the region of 32,500. So again, greater pressure and resources needed in the system to do that. And then equally on the right-hand side, the number of people aged over 65 in Herefordshire with a limited long-term illness projected to 2040. So you can see that increase. And with the financial challenges we're facing, we need to operate in a different way. And I completely understand there's lots of fantastic work going on, long-term conditions strategy the ICS are working on, and also the One Herefordshire Partnership doing lots of work around long-term conditions. So I think these challenges are well known, but it's really helpful to kind of map what those future modelling might look like. And we've just had a long conversation on frailty and falls, so I'm not going to go into huge amounts of detail on that, but we know that 10% of people aged over 65 live with frailty nationally, and this rises, you know, as people age. And again, there's lots of things we can do to help people reduce the consequences of frailty, and muscle strengthening exercises and things like that, which I'll come on to. And I think it was last year, 7,840 over 65s were recorded as having a fall in the last year. So there's lots we can do about that. And we've already talked about the rugs and slippers and things like that. So it's going to be a real challenge for us, particularly with our rural access and issues across the county. Dementia again, I think dementia often, there's assumptions that dementia is inevitable and it's quite widely prevalent, but actually it only affects about 3% of the population, so it's probably not as widely prominent as we think. But that said, we need to diagnose dementia early, as we've already talked about, and support those people that do have a diagnosis. And again, with the ageing population, we will likely see more people with dementia. So at the moment, we think there's around, so the estimations we talked about earlier, 3,200, and we think that's going to rise to around 5,500 by 2040. So again, these are issues for both health and social care services. And then there's the healthy behaviour. So often Michael's already talked about that, and these 4 health behaviours are always kind of talked about in the context of public health because they are so relevant to all ages really. So physical activity, as I come on to in a minute, we know that about 20% of all adults do less than 30 minutes physical activity a week, so that's 1 in 5. And we know that as people age, there's an assumption that we need to rest and relax. And whilst there's an element of truth in that, we do need to keep active. We know that actually after the age of 30, your muscle mass reduces by around 3 to 8% every year. And it goes even significantly higher than that once people hit the age of around 70 to 75. So we need to keep our muscles active, we need to keep using them, because we know that actually muscle functioning is a key cause of disability as we get older. And it's something we can all do quite easily, even just walking, gardening, dancing, anything like that. And then smoking, we talk a lot about here as a board. There's about 3,000 residents over the age of 65 who smoke, and we know there's some immediate offers coming online soon across the council to support people help give up. Ideally, we like people not to take up smoking in the first place, but we know that's a leading cause of a reduction in life expectancy. Healthy eating and healthy weights, we talked a lot about before, and then alcohol, again, that could be quite a key risk factor, particularly in terms of increasing the risk of falls, and just encouraging people to drink healthy. I quite like this diagram. This was in my report where it's very much talking about functional capacity. So this is a bit about what I just talked about really, about, again, it's that misconception that as people age, they should slow down and rest. But actually, this diagram illustrates functional capacity is basically the person's ability to do everyday activities. So it could be bending down to put your clothes on or those kind of things. It's really, really important for independence. But this diagram just shows the green line is somebody who stays active and they maintain their functional capacity as they get into older age. So that stays relatively high. And then the sedentary lifestyle, so people that don't do much physical activity, that orange line is quite low, and they have a lower level of functional capacity. And you can see that just drops off significantly. So by keeping active, that can play a significant contribution to reducing demand on health and social care system. But as I said, your muscle mass does reduce quite significantly from the age 30 onwards. I told you it's quite negative public health, isn't it? But I did start off with some positive things. I've touched on the social connections a little bit, but I think we probably just need to emphasise the importance of loneliness and social isolation. Yes, it often gets attached to older people, but we know that it's very common amongst younger people too. And there's some well-published research now that being lonely can equate to smoking 15 cigarettes a day in terms of the wider health consequences. So there's lots we can do, and I know there's lots in the mental health action plan in terms of things to address that, and through the community paradigm amongst other things. And then the other statistic I found quite interesting is 28% of those aged 65 live alone in Herefordshire. So again, we've got lots of people living alone. It's how we connect them into the community. Unpaid carers is another really important one as well that we've talked about. So again, 21% of Herefordshire adults provide some level of unpaid care, and we know unpaid carers can often disproportionately have worse outcomes. So again, there's lots of work going on around carer strategy, which I'm aware of, that would be really helpful to apply to that. Digital literacy, in terms of how people engage with the internet and literacy. Obviously, there's a move around digitally and people engaging services through that mechanism, but we know that there needs to be alternative ways to do that, and Talk Community is a fantastic resource to support that. Other things around the environment as well, so the environment we live in terms of excess cold and heat. So again, that's quite an issue in Herefordshire with our older house stock. So we know that cold homes can be attributable to excess winter deaths. And I know the ICS doing a lot of work through that, and that's a key area we want to focus on. And then transport and mobility, really big for Herefordshire, isn't it, in terms of virality and access, enabling people to see their friends and family. And that's something that we continue to need to look at going forward. And then finally, unsafe homes. Again, we just touched on that a little bit. Home aids, adaptations, fall hazards. You know, how do we get people to live in those home environments that reduce the risks of falls and things like that? So throughout the report, and I've not really gone into any great depth of this presentation, I've kind of really tried to draw out all the great things that are going on in Herefordshire. Again, you know, lots of fantastic initiatives through the voluntary and community sector that are meeting some of those needs out in the community already. These are just a few I've kind of highlighted, but they're throughout the report, so do have a read. There's plenty more, and I completely recognise that. You know, we've got a wealth of voluntary and community sector organisations out there. There wasn't space to include them all in the report, but I just wanted to acknowledge that that they are out there, and they're doing a fantastic job. So in terms of the actions and recommendations, so there are just two slides that I was going to cover really. One is for individuals and community, and I recognise some of this is in traction already, so this is appealing for our communities and residents. You know, the things that we talked about in terms of supporting people to be healthy, volunteering, joining a community activity, computer skills. So lots of things that we can ask our communities and residents to try and do to help themselves. We recognise that they have a role. And then there's also activities that we can do collectively as public services, which I said much of this is underway actually. NHS Health Checks is a really good opportunity to really shift upstream between the ages of 40 and 74, get that health MOT early, see if you can identify health conditions and then put those actions in place. Personalised care, lots of work nationally and through the integrated care system. We've known that for a long time. You know, matters to that individual what they want to do, wrap the support around them. I think Mike alluded to it earlier around the mental health, kind of how do we make the support available to people? How do they know where to go? How often do we go to workshops and meetings and people say, I don't know what's available to me, I don't know where to go. Talk Community is doing a great job. We're doing some great work around developing that directory of services, but I still feel there's probably more we can do to make it easier for people. Voluntary and community sector, I think there needs to be more investment and support. The VCSE, fantastic job, often work with some of the most seldom heard communities. How can we support them more? And then community engagement in older people in local planning development. So when we're building all our new houses and housing stock, how can we bring older people into that conversation so we actually make them age friendly? And I think that's really important. I'll probably stop there. Just a few acknowledgements from some colleagues that helped me with my report, so I give my thanks to those. Happy to take any questions from the board.
I think it's a really good report. Thank you very much. And I'm grateful that you've acknowledged the role of the VCS sector in terms of its contribution, because sometimes it is missed, as we've alluded to at some point today. If I may put my day job hat on in terms of physical activity, I recognise the statistics in terms of as we get older, physical activity. So what, in terms of the prevention agenda needing to get upstream in terms of whether it's the falls agenda that we were touching on before, or whether it's like loneliness, isolation. So I appreciate the call to action is we need to do something here, but have you got any thoughts on what we need to do or how we end up doing it?
With falls specifically, or physical activity?
Falls in one compartment, but general physical activity as a force for good, because a lot of people know physical activity is good for you, but yet the 20-odd%, the 1 in 5, still don't. So we need to get proactive in that space, but in a preventative way in terms of the falls, it's very logical that prevention is better than cure in that sense.
Yeah, that's a good question. Because I teach physical activity at UE quite often, and there's a term I used to use. I'm not sure people are aware of how much activity they need to do, is my first point, and I like to call it physical activity deficiency. I think we're actually deficient in physical activity, and I don't think people realise how much we should do. So that's my first point. So I think there is still something about, particularly with older people, to raise awareness that they need to keep moving, they need to keep active. So as I said, I think they do often think, maybe they don't, that'd be my view, is they just sit and rest, but actually they're keen to keep moving, and that's good. So that's my first point. I think there's a couple of things there, Steve. I think for specific stuff is quite structured, isn't it? And I think there's different levels. So I think we can do more around social prescribing and building on kind of dance on prescription and kind of those light physical activities. Tai Chi, there's some really good evidence base on that reducing falls. So I think there's more of the kind of softer community physical activity interventions we should really be pushing and promoting. But then we need to support those somehow, whether it's financially or working closer with Halo. So that'd be my first point. And then there's more structured force things that I think we need to do around the kind of a Targo that are kind of a bit more evidence-based in terms of they can specifically reduce people that are highly risk at falls. So that's the kind of those things. And then I think Councillor Gandhi talked about it earlier about the kind of the risks of around the home and how we kind of prevent people. So I think it's, I mean, you know, from the physical activity strategy group, I think there's probably a whole system approach of a menu of different interventions at different various levels that we probably need to put in place.
Yeah, I think you also mentioned the isolation one. I think the difficulty with that, so whether it be talk community or whether it be good neighbour schemes or whatever there may be in the county, it's really difficult to find out where those people are that are behind that door and you don't know about them, and you know the GP practice may well know who they are, they may visit them, etc., etc., but the voluntary sector organisations, unless those people come out of their houses to the talk communities, or they ring the Good Neighbour scheme and ask for someone to collect a prescription or something, you don't necessarily know they are there, and it's really difficult. So I live in a relatively small village. I know a lot of people, and I know that if somebody doesn't come to a coffee morning for a couple of weeks, someone will go and find out what's wrong. But if that person's never come to the coffee morning, and how do we find them? And that is the problem. And particularly in a rural area like Herefordshire, where you've got people living in really isolated areas where they've got no neighbours around them at all. You just have no knowledge of the fact that they are struggling.
I mean, but I alluded to the Feel Good for Life example in there, and actually many years ago in another life when I used to teach cardiac rehabilitation actually, and people weren't coming to prevent their risk of, you know, having another heart attack actually. Well, they probably did to start with. It was actually just coming along and having a biscuit of coffee and you know, being with other people, and the physical activity almost became secondary, and they got benefits from doing that. So it was a social connection thing that was the kind of the hook for people, and then the physical activity came second. So that was quite powerful.
To a degree, that's what happens at Halo, because I went along to Halo where they were doing cardiac rehabilitation, and talked to some of the people there that were doing very light exercise that they've been recommended by their GPs to go along and do. And the actual session was only probably an hour, and they were probably only told they needed to go a couple of times a week, but they were going every day. When you talk to them, they say, we go every day because once we're hours up, we can go downstairs in the coffee shop and we can sit there all morning and chat. And we do that every single day. So it is a mix of things.
Yeah, a couple of things. I mean, one, I think interesting. I received or heard a presentation from Malvern Hills District Council a couple of weeks ago about their new leisure strategy, and they described some of the stuff they're doing. But specifically for this board, they referenced some work in Herefordshire that they'd come and visited and built upon. So just worth noting for your local work here is reaching beyond the borders of Herefordshire, shall we say. The second thing I want to say is you may or may not be aware, but we were recently successful in being awarded some funding from the Department of Work and Pensions to run a service called Work Well from the 1st of October, which will enable us to put in place a new service that if there are people living in the community and working in the community who are at risk of falling out of employment because of ill health, whether that's physical ill health, mental ill health or a disability, then there'll be a new service that they can access to help them overcome the barriers that may help keep them in work. And when we talk about the context of kind of wider determinants, physical activity, keeping people in a job, I think the potential health benefits of successful services in that area will be huge. So we'll do some more promotion work and make you aware of it more, but just get it on the agenda early that there's a new service coming in a few months focused on that.
Yeah, just thanks for the report. It's a really cracking read. And so I guess I mean, there's all sorts of things we're doing about this, aren't we? And we have been doing for quite a while. But actually, when you look at the numbers, it's just getting worse, isn't it? That healthy life expectancy number that particularly for men is going down. So I guess there's all sorts of societal factors in there, aren't they? It's not necessarily we're doing a bad job. There's all sorts of facets for why that's happening, but it is something we need to be really concerned about. But also, when I looked at the dates, and actually, it's really out of date, isn't it? Again, so actually, the figures we've got are 1820 for that healthy life expectancy data. So actually, we're 4 years on from that now. So has it got worse? Has it got better? Is there a way of us understanding that more in real time?
Yeah, we don't have that data, so that's some of the kind of limitations we're working with. So it's a really good point. I probably should have alluded to that, but I mean, I don't think there's going to be, well, we don't know where it's probably gone over the last few years. I think there's a view that it's probably, if it's plateaued at best, maybe gone down at worst. I don't think there's any expectation it would have gone up either for healthy life expectancy or life expectancy, being honest.
Yeah, no,
So it's not a positive picture, I don't think. But that, yeah, it's very complex reasons behind that. Whether I'm conscious we're in a PERDA period, so it's difficult for me to say too much.
Yeah,
but
yeah. And then I guess the other issue is the health checks that you talked about, sort of between 40 and 74. So how do we do on that? And do we track then what happens as a result of that?
Good question. In terms of how we're performing, I can't remember where we're at now, but we're actually, I think we're one of the best in the West Midlands in terms of number of people being inviting for NHS health check and completing health checks. I think there's some really good partnership work with tourists on that front. In terms of tracking them, no, but that's a really good opportunity and something to think about going forward. But the evidence is quite good now in terms of they do make a good difference in terms of improving outcomes, but that's one probably for me and Mike to take away, or someone else.
Thanks.
Yeah, just on that health check point specifically, one of the things that we're interested in the ICB is the health inequality issues around health checks, because what we don't really want to be doing is having lots of fit and healthy people going for a health check and confirming that they're healthy. That's good, but what we really want is the people who are not sure whether they're healthy or not, and there's a kind of a bit of an inequality gap we've got to tackle there. So we need to spend some more time focusing on getting the right people in for health checks.
point?
I can't remember. I think it's probably the evidence, but it doesn't include people that you only do a health check of people that don't have a long-term condition already. So I suspect because over the age of 74, a lot of people will probably have a long-term condition. So it's very much a preventative thing rather than a kind of a treatment thing.
I was just going to add to the health check stuff is, I think the worried well effectively attending GP practices has been, I think, where we've been at. I think, but now we are seeing a change in that. I think in some of the data of where if it's been on the high street or going out into communities, I think we're seeing a change in that. So I think that's really positive. And I think there is a lot of flex that we need to be thinking about how we change those age groups and various things and how we evolve that. And very much kind of think about how we can all be involved in health checks, not just doing it around a contract. So there is something around that as well that I think we can evolve. But certainly it's made a big difference in the last year compared to the last 5 years for me. It's been, we've seen a big difference this last year. So I think it's going to change significantly more as we move that forward.
What way has it changed?
The numbers of health checks that are happening, the more systematic approach to it. So it was for general practice, it was probably the bottom of their list of priorities, being honest, around just because of workload. And so now having something dedicated to it, has it made a big difference for supporting the practices to deliver that, and to add, to look at the gaps that's happening and that partnership working. So I think that's what we're seeing differently is the approach. I think it also is about access. So access to general practice, I won't talk too much about now, but we know it's more challenging than it has been in the past. And so if it's challenging just to get to somewhere when you're unwell, it's really, really challenging to get to somewhere when you're actually feeling reasonable, when you're already well and you're trying to be proactive with your care. So actually, we do need to make access to prevention services high up on the agenda, and I think that's one of the questions of how we facilitate that.
Yeah, so just presenting the work programme for upcoming meetings. It's as much for information and just for the board to see at this meeting.
Can I just add a quick one? Obviously, good to have a decision around the. Actually, no, ignore me. Early next year, probably suicide prevention strategy. Could that go on when you've got the date set for that, Henry? I guess that'd probably be February, March time.
Suicide prevention
strategy.
The work well thing. Report later.
The hat on around the physical activity strategy. Do you know if then is that due an update and when that might be?
Probably, yeah, it is due an update.
Got it down to September.
Okay, I think it'll be fine for September. I'll just say that, I won't be here, but I'll commit him to it. I think it'll be fine for September. I'll have to follow up on that one. Yeah, I'm not sure. Do you know, Mohammed?
Yeah, so we are doing a review of the implementation plan of the health inequality strategy now. I'm not sure whether we're going to have something ready in July about the plan, because we have started now in the HIP board to review the plans. September, sorry. Yeah, I can liaise with Bobby Morris, the chair of the HIP board, to see if we can provide an update. Thanks.